Good afternoon and welcome to Breathmatters. I am Joan Shiflett and I'm the president for Breathmatters. It's a pleasure to have you. But I'm going to turn it over to Dr. Jim O'Connor, who's going to be sharing with us related to COPD and palliative care. I'll let Jim introduce himself.
Thank you very much for having me, and thanks for all for joining. And hopefully you can hear me all okay. Can everyone hear me okay on Zoom?
Yes.
All right. So I'm Jim. So I'm one of the pulmonologists at VCU. Did my medical school and residency training at VCU or MCV, and then did my pulmonary training in Alabama at UAB, and then came back here in 2019. So I have a special interest in COPD, but I also see all other lung diseases. This talk today will be about palliative care within COPD, but can apply to other lung diseases as well. So I have a few slides we can go through, but feel free to stop me throughout the talk, and if you have any questions anytime, or can wait till the end, or feel free to add some comments or questions in the chat as well. Is there any questions before we get started? Or? So the kind of goals of the talk today, and we'll talk about COPD, what is COPD, how we can integrate palliative care within COPD, and then a little bit about symptom management of COPD in addition to the normal care we give to our patients. This graphic here kind of outlines what palliative care is, and I'll go into more of that in the talk about what palliative care is. We haven't heard that term before, but it kind of encompasses these four kind of tenets of how do we manage symptoms and supporting our patients, how we support our loved ones and our family and friends who help us. We'll also talk about advanced care planning, what that entails, and our goal of improving quality of life for all of our patients. And this is accomplished on the outside here with about all the arrows of who is providing the care. So physicians or volunteers, the palliative care team, social workers, nurses, nursing support. So it takes a whole village. So just to overview what COPD is, COPD stands for chronic obstructive pulmonary disease. The main risk factor, over 80% of patients, is related to tobacco smoking, but other risk factors for COPD are exposures to toxins in the air. In other kind of underdeveloped countries, indoor cooking with kind of biomass exposure can be a risk factor for COPD. There are some genetic conditions, the most common being a condition called alpha-1 antitrypsin deficiency, which can lead to COPD. This varies year by year, but why it's important, of course, to someone who does have COPD, but in general throughout the country and worldwide, it's the fourth leading cause of death here in the United States, third leading cause of death in the world. I think it's about 12% global prevalence, but this is likely under-recognized, and actually more patients likely to have COPD than we actually are diagnosing. It can be, of course, the direct cost to the patient, of course, but also to the healthcare system of over $30 billion. A lot of that is due to kind of hospitalizations that we call exacerbations, when patients have worsening symptoms and need to be hospitalized or require more treatment. I think this is not unique to COPD in terms of the symptoms, but most patients with COPD will have frequent coughing or wheezing, excess sputum production, shortness of breath, of course, can be a symptom of COPD, or even trouble taking a deep breath, but not unique to COPD itself. So unfortunately, you can't just diagnose COPD based on symptoms. So how we diagnose COPD is on spirometry, so pulmonary function testing. We use certain criteria to diagnose. I think a lot of confusion sometimes even within the care team is We use terms interchangeably, things like emphysema and COPD. They're not quite the same. Emphysema is what actually we see under the microscope or see on a chest X-ray or CT scan. That's what the exposure or smoking happens to the lung, where actually can destroy some of the lung tissue. But not everyone who develops emphysema will develop COPD. Certainly not everyone who smokes will develop emphysema or COPD. But we use pulmonary function tests to give us the criteria to rule in or rule out someone with a COPD. So we use this ratio here. This FEV1 stands for the forced expiratory volume in 1 second. FVC is the forced vital capacity. That's how much we can blow out kind of total until we almost kind of pass out. So if anyone's done these rhythm tests, can relate to the ratio of less than 70% is the criteria for diagnosing COPD. And once
I'm having a little trouble with what some of these things mean.
yeah, so
Like FEV1 and or all that gold, 1, 2, 3, 4. What? I'm sorry, I don't know.
yeah, no, good question. So the what GOLD stands for is the Global Initiative for Obstructive Lung Disease. That's our COPD guidelines that help us. They're updated periodically every year, every couple years, to help us give updates on COPD and how we treat and how we manage patients. So let me move the. I'm going to move the Zoom out of the way for a second. But this diagram here helps us go by. So here we're diagnosing based on the breathing tests. So when the respiratory therapist will have a patient go through certain breathing maneuvers, and the FEV1 is how much we can blow out in 1 second. So it's how much volume someone can breathe out in 1 second. And the FVC is the forced vital capacity, how much someone can blow out total, kind of empty their lungs. And anything more than 70, so more than 0.7 is actually normal. Below 0.7 is what we call airflow obstruction. So air is not getting out normally. And then the next box here is looking at the different grading, the kind of severity of the airflow obstruction. And then the last part here is actually how we grade someone's overall COPD diagnosis. And there are really 3 categories. And that's the A, B, and E. And I'll get to this a little bit later in the next few slides, but we grade someone, we group someone's COPD based on how much symptoms they're having, and also how many exacerbations they're having. So are they having need for antibiotics or having worsening symptoms, or they're being hospitalized frequently in the hospital. That's how we differentiate the A, B, and E. After we diagnose a patient with COPD, we want to search for what caused the COPD to either related to cigarette smoking. We encourage patients to quit smoking, or if they're being exposed to secondhand smoke or other agents in the air, then we try and modify those risk factors. Get back to my PowerPoint. Any questions about how we kind of diagnose COPD?
So is the A, B, and E the same type as the GOLD? What used to be mild, moderate, severe, very severe?
Mm-hmm.
So is the A, B, and E the same concept? So A is not so bad, B is maybe a little worse, and E is, my goodness?
Good question. Yeah. So probably about 5 or 10 years ago, we would use the grading based on the severity of someone's pulmonary function testing. But we learned that not every grade is the same in terms of someone's symptoms. So they moved to this A, B, and E scoring or grading grouping, actually called the group A, B, or E. A being the kind of less severe. So looking at the A here is that patient is having minimal exacerbation, so their COPD is not flaring up. They're not being hospitalized, and they're also having minimal symptoms. And I'll get to what this MMRC stands for, what this CAT, those are scoring kind of systems to help us determine someone's symptoms. E is the most kind of severe grouping of COPD, that those patients are having more exacerbations or being hospitalized, and are actually having, their symptom burden can be either low or high, but we're moving more toward that. We know that when patients are hospitalized for COPD, that's not a good thing. And kind of harder for patients to recover back to the kind of baseline symptoms after hospitalization. So in the clinic, we'll like to see what someone's lung function is based on their breathing test. That's really what are their symptoms. That'll kind of guide us on how to treat patients based on their group.
I've seen this online, but my doctor still goes by the old style, the mild, medium, or moderate, severe, and extra severe. So I was just wondering about maybe.
Yeah, it's still important to know someone's lung function, because that we do know lower lung function patients sometimes can be at risk for getting worse. Pure will track lung function with breathing tests to see if things are changing in terms of lung function. Outside of COPD and other lung conditions, lung scarring and pulmonary fibrosis, we'll use different criteria for pulmonary function tests and track different parameters for those patients.
What about the patients that have multiple issues? How do you track them?
Similarly with the breathing function test, but also if there are certain procedures that patients might benefit from with certain lung conditions. So for COPD, for example, you might have heard of endobronchial valves. Heard of those type of procedures where you actually can, or there's something called lung volume reduction surgery, where actually you can remove parts of the diseased lung. We use the breathing test to determine if someone's a candidate for certain procedures. So.
Could I get you to repeat the question so that people remotely can hear it?
Yes, yeah.
Thanks.
Yeah, very good. So the initial question was, some doctors still use the grading of our lung function based on our pulmonary function test to determine the severity. But more recently, we're using this grouping A, B, and E to determine someone's status of their COPD. But we still use the grading to track someone's lung function over time, or to see if they benefit from certain procedures, or even talking about lung transplantation. Yes, ma'am.
Is an exacerbation in medicine, does that mean an event? What does that word really mean?
Good question. The question was, what is an exacerbation? It's actually pretty simple. It's really a change in someone's, if they have a baseline shortness of breath, if it's worsening. So if they're more within 7 to 14 days. So it's not kind of a slow, gradual, my breathing has changed over 6 to 12 months. It's more, the past week, my breathing has gotten really worse.
Some people refer to it as a flare-up.
Something like an event.
Yeah, my mom had them 3 or 4 times a year.
Yes, it's really, most of them are a flare or exacerbation is triggered by an infection, pneumonia or bronchitis, or someone is still smoking, that can trigger an exacerbation. There's different severities of an exacerbation. So here being moderate, being not requiring someone to be hospitalized, and the more severe are someone needing to be in the hospital for really severe flare-up. If they're needing IV treatments or frequent breathing treatments, or even needing to be in the intensive care unit, needing a mask to help them breathe, or having to go on a breathing machine. questions, I'll the next slide here. So while we're talking about COPD today, but like I said, some of this can apply to other lung diseases. This is looking at kind of the burden of COPD for patients and loved ones. So I think a lot of what we try and do in the clinic is, of course, diagnose a patient and talk about what treatments we're recommending. But a lot of times we don't always sometimes address the other things that are happening with our patients. We're in the clinic trying to talk about inhalers, talking about oxygen, talking about what are pulmonary function tests. A lot of times we don't have a lot of time to speak about what else is affecting the patient and what's their understanding of their disease. So for example, understanding that sometimes we don't always recognize that we're actually having symptoms and trying to just normalize when I'm getting older. So maybe this is what should be happening, but really I truly actually have a lung condition. Sometimes COPD and other lung conditions can be isolating, and of course having symptoms might limit you to be able to leave your house or do the things that you enjoy doing. And then this kind of sustained symptom burden can lead to other symptoms like fatigue, anxiety, social isolation. So all these other things are, of course, very important, or even sometimes more important than the actual COPD itself. And it's something we kind of look at more from a bigger picture of why we think COPD is important and how we and why it can be costly to patients and their families is that something called this global burden of disease study that looked at years lost from dying early, but also having disability from COPD, and actually COPD is kind of the second leading cause of kind of this reduced disability adjusted life years, only secondary to ischemic heart disease and coronary heart disease. Any questions about kind of this is looking at really what's the entire patient and not just breathlessness or other respiratory symptoms, but looking at other symptoms that are important to patients and their families.
Do you know about the percentage of people that actually don't have heart disease?
Good question. So that kind of leads me to my next slide, is that COPD can run with other symptoms and often coexist with kind of this long list of other conditions, and that can both contribute to symptoms of shortness of breath and cough. So usually patients don't just have COPD by themselves. Usually they'll have other conditions, such as heart disease. I don't have a percentage per se of someone has COPD, but their risk of having heart disease. But we know that overall, this is not just an exhaustive. This is not the entire list, but there are other conditions that patients can suffer from as well. We use this term multimorbidity, having two or more kind of chronic conditions, either COPD and heart disease. Having kind of multiple conditions can lead to more issues. So the other things, patients who said the most common cause of COPD is from smoking. Patients, of course, can be at risk for lung cancer, can have diabetes. GERD stands for gastroesophageal reflux disease, so GERD or reflux. Bronchiectasis is another type of lung disease that is related to dilation of the airway tubes. And OSA, obstructive sleep apnea. So patients a lot of times we'll be screening patients if they have COPD for these other conditions to make sure that they're not contributing to their symptoms. And then this is a busy slide, but on the top right picture here, the bottom right here, to the top right, here's how we actually treat the different groups of COPD, and based on inhalers. So inhalers are just one way we treat COPD. But for example, in a group A patient who's not having lots of symptoms, we'll recommend a as-needed bronchodilator, so like albuterol. So if the patient is feeling otherwise well, can just have a rescue inhaler or albuterol inhaler to carry around with them, or have a nebulizer machine at home to help with their breathing. And then for our group E patients, for example, those patients who are either having to be in the hospital a lot or having frequent flare-ups, we'll kind of escalate their inhaler therapy to a more, what we call maintenance inhaler. So a LABA stands for a long-acting beta agonist. It's like a long-acting albuterol, and then adding a long-acting muscarinic antagonist. So that's a LAMA. So we use all these kind of terms that can be kind of confusing. But these are the different medications that we put in inhalers that can help patients with breathing and also help keep them out of the hospital.
What is this? LABA, LAMA, what is that?
Yeah, so those are just the abbreviations for the different types of inhalers, different medications. So you'll see on TV or seen with in the doctor's office that you probably have about 30 different inhalers that you can prescribe. They're in these different classes of LABA or LAMA. So for example, like Trilogy, if you're reading that on TV, that's a combination inhaler that has 3 medicines in it. We escalate increased inhalers if patients are having more symptoms. As they start getting better, we can often discontinue certain inhalers and go back using maybe an as-needed inhaler.
Is ICS, is that a biologic drug?
Good question. So the question was, what is an ICS? So an ICS, that stands for inhaled corticosteroid. So that's a steroid that we can give through an inhaler or sometimes even through a nebulizer machine. Typically, we use more ICS, inhaled corticosteroid, in patients with asthma, but they also can benefit patients with COPD. Yes, ma'am.
So can asthma develop into COPD?
Good question. The question was, can asthma develop into COPD? And yes, it can. So usually uncontrolled asthma, if it's not treated effectively, can lead to kind of chronic airflow obstruction. So you think of asthma more as a variable airflow obstruction, and COPD is a more persistent airflow obstruction. There's different types of asthma. As usually think of asthma as for kids, and then growing out of it. But you can develop asthma as an adult. I think there's different types, like exercise-induced asthma or asthma related to allergies. But yes, asthma can develop into COPD, and then there's also some debate that patients can have asthma and COPD, have both conditions. So sometimes it can be hard to tease out which one is causing more problems. Is it someone's asthma in the air? We're probably one of the worst places in the country for allergies and asthma, so asthma is actually very, very prevalent here in the Virginia area.
So if you have asthma, say you got it as a child, and you didn't smoke as a child and you smoke as an adult, is that not a good thing?
Say
Yes,
so.
it's not a good thing.
I would agree. The question was,
Because smoking didn't cause you to get asthma, because you got it somehow you got it as a child, but you shouldn't smoke as an adult.
correct, yeah, or even as a kid.
I don't know any kids that smoke right now.
But yes, even secondhand smoke exposure can make asthma worse. You can any kind of things inhaling in the air, perfumes or dusts, chemicals if you're cleaning your house, certain cleaning products can trigger asthma to be worse. So that can even if patients have COPD, can trigger their breathing to get worse. We usually think if someone's having lots of flares from something in the environment, they might have more of an asthma issue than COPD. And then this is a little bit more busy down here, but this is how we, once we start inhaler, we'll then assess someone's response to it. Is it helping their breathing? Over here, if it's not helping their breathing, we just start them on a LABA, for example, then we'll add a LAMA to their LABA. So,
Can you give an example of those types of medications? I know there are 3
yes.
general types, but
Yeah, so-
the brand names that we would know?
Yeah, so for a LAMA is Spiriva, or
Spiriva?
tiotropium,
Okay.
and then a LAMA is, we don't usually use a LABA by itself very often, so it's usually within a combination inhaler. So something called a Noro, if you've ever heard of that or seen that on TV. The Noro is a combination LABA and LAMA. So it has two medicines in one. Kind of. It gets kind of confusing when we use all these terms. And then a LABA LAMA ICS, that's a triple inhaler. That's something like Trilogy
Okay.
or Respiratory. Those are examples of a triple inhaler. And then a LABA ICS, is something like Symbicort. If you've heard of that before, sometimes we use more of that asthma patients, but sometimes you'll see some patients are on Symbicort and Spiriva. That's sort of similar to the Trilogy. So you get actually in our
Lots of different combinations.
yeah, so in my clinic and most clinic will have actually a sheet of all the different inhalers to go over it's going to be even confusing for us of so many inhalers out there, which ones are best to use. So. Yes. Yep, I hear you.
Can the inhaler be good for IPF?
So the question was, can an inhaler be good for IPF? So IPF, idiopathic pulmonary fibrosis. That's a lung scarring condition. Inhalers typically won't help with lung scarring conditions, but some patients can have lung scarring and COPD. And actually, based on kind of going back to an earlier question, can someone have 2 different lung conditions? Sometimes the lung scarring and the COPD part can cancel each other out on a breathing test. So some patients might have a subjective or feel better on inhalers. But based on lung function tests, may not show improvement. Does that answer your question? Does that make sense? Does that answer your question?
You might be on mute.
Not kind of. I have a question. Improve the shortness of breath.
Yeah.
Make it harder.
So it like I said, it could help with symptoms. So a lot of times, as we're trying to figure out someone's lung condition and giving them a diagnosis, we'll try inhalers to see if they will help, or try a nebulizer machine, so a machine at home, and a little box that you can hook up to a mask or a pipe and administer medication through, and that could help someone feel better. But
I'll ask Dr. Brown.
but it may or may not help. Like I said, they usually don't help, unlike in COPDs where these are actually used for. In lung scar conditions, they typically don't help. Like I said, some patients can have multiple diagnoses.
Thank you.
You're welcome. And then this other bottom part slide here looks at if someone's having lots of exacerbations, how do we adjust inhalers? And then on the left here, I've listed just some of the treatments for COPD. So, the top here the most important thing that someone can do who has COPD is to quit smoking. It's easier said than done. Yeah, I could give a whole talk on how to help with smoking cessation, but it's really can be one of the harder things to quit. So sometimes it takes multiple times to try and quit. And then avoiding other secondhand tobacco smoke or other kind of air pollutants that might be contributing to someone's breathing problems. And then inhalers are really the mainstay to help with symptoms. Sometimes we'll use things like steroids or prednisone as an anti-inflammatory medication that usually will reserve for patients who have a flare-up of COPD or if they're in the hospital. We'll use antibiotics like azithromycin to help prevent flare-up from happening. And there's a medication called Refreshments. It's a pill that can also help with decreasing the amount of exacerbations or flares the patient is having.
Comments,
yes.
question right here.
Oh, sorry, yes.
Have you got to, the Breathmatters, I can't say the word.
Yep, azithromycin, yep.
Yeah, I was prescribed for it for IPF, well, yeah, that's what I have. And my newest doctor, Dr. Varela, said not, that I need to take it. But I read that you should, so I think I'm gonna go back home and talk to him about it.
Yeah, so the question was about when do we use azithromycin, and we'll use it a lot for the short term. So if someone has bronchitis or a pneumonia, we'll treat someone for pneumonia for usually 5 days. But we'll also use it for patients who have COPD if they're having lots of flares despite.
Once a month,
Yeah, so
just as a preventive.
yeah, so usually if someone's on a triple inhaler, so if they're on something like Trilogy and they're still having issues with their breathing or needing to be in the hospital, we'll add azithromycin to help them keep them out of the hospital. Sometimes there are side effects to any medicine. The main one for azithromycin is it can affect one of the can put you at risk for maybe a heart condition, so we have to monitor someone's EKG periodically to make sure that it's not causing problems.
What would be the reason to have lung volume reduction surgery?
Good question. So the question is, when would we do lung volume reduction surgery? Why would someone go through that? So I wish I don't have a picture here in this slide, but our normal lung is made of all these air sacs, the alveoli. And what happens with smoking is that the cigarette smoking can damage the walls of the alveoli. Instead of having little tiny alveoli all kind of stacked on one another, it makes one giant big alveoli. And that's what makes it hard is when trying to get air out when we breathe, the air can get kind of trapped back in our lung and not actually get out. That balloon.
So it increases air, isn't it?
So actually what happens is if you have a balloon, I like to think of our lungs as a kind of big balloon that if air gets trapped in there, the more air you breathe in, you can't get it out, the balloon will get bigger and bigger. And that balloon, the more air you put in it, could pop at some point. So what happens with the lung volume reduction surgery is actually you remove that big balloon and actually can help the other parts of the lung that are normal breathe easier. Does that make sense? So that's how I kind of like to think of why we do surgery for COPD. So not every patient that has COPD would develop these giant balloons in the lung. That's why we use also the endobronchial valves. If you've heard of those, these are little valves we can place in the lung to help kind of collapse that balloon, make sure it's not too big, and have other parts of the lung that are more normal do all the work instead of that big balloon that's not working appropriately.
So if someone cannot have lung volume reduction surgery, is that when you would do the valves or the other way around?
Good question. So the question is, when do we decide about the valve procedure or the lung volume reduction surgery? The endobronchial valves are a less invasive procedure. The pulmonologist, a lung doctor, would put what we call a bronchoscope, going under anesthesia, put a little camera down into your mouth, through the vocal cords, through your windpipe, and down to the lung that is abnormal. So there's no surgery, there's no cutting, so it's a better tolerated procedure. The lung volume reduction surgery is a more involved surgery where they have to do an incision in the chest and remove the diseased lung. So it's a more risky procedure. So if a patient maybe is not a candidate for a surgery, would maybe go down the valve route.
But would you want to do the valve to just about everyone, because it's not as invasive as taking part of the lung out?
Okay, good question. So the question was, if the valves are less risky, should we just be doing the valve procedure? The valves are a newer procedure, newer intervention within the last 5 to 10 years. They've been doing lung volume reduction surgery for longer than that, so we know probably a little bit more about lung volume reduction surgery, had more studies on it, so we haven't compared them head to head. So if someone's a candidate for a surgery, would recommend a surgery. Similarly, bulectomy, just below the lung volume reduction surgery, that's similar to the lung volume reduction surgery, but actually removing something called the bulla, and that's the big kind of balloon, taking out the whole balloon. And then other things that we'll do before we kind of get to, this is kind of going from the top, what you do first, kind of going down to the bottom of the last resort is a lung transplant. I think Dr. Patel spoke recently about lung transplantation. But before we get to that, we try these other things to avoid surgery if we can. So I think doing things like pulmonary rehabilitation, getting our vaccines for influenza and pneumococcus, type of pneumonia, and then using oxygen if we need it or qualify for, and then using things like non-invasive ventilation, so using like a CPAP mask or a BiPAP mask at home to prevent patients having to go to the hospital or having a flare-up. Any questions about the overall treatment of COPD? This would be a whole, each one of these things can almost be a separate talk. Right, so kind of moving on to the crux of the talk today is palliative care. Has anyone heard of this term before? Palliative is derived from the Latin root palliare, which means to cloak. It's a specialized medical care for patients living with serious illness. The goal is to improve quality of life for both patients and their families who are helping take care of patients. And then palliative care is actually for any stage of disease and really for any patient who has a severe illness. Can even be administered as someone is receiving treatment to cure their illness. So if someone, for example, is diagnosed with leukemia or a blood disorder, if they're undergoing chemotherapy and hopefully trying to cure them of their leukemia, can also receive palliative care. It's different than hospice care, I think. Sometimes we equate palliative care and hospice to be the same, but they're separate treatment plans. Hospice is an approach to care focusing on comfort and quality of life. Someone's approaching the end of their life. We typically think that they have less than 6 months to live, but patients can enroll in hospice and can live for a year or more than that and still be enrolled in hospice. So, because if someone doesn't pass away in 6 months, doesn't mean they have to disenroll from hospice. So.
Jimmy Carter.
Yeah.
So it's just a treatment plan where we're shifting our goals of if someone's not wanting to come back to the hospital, not want to come back to the clinic, if they want to be at home, be comfortable. That's today what we think about for hospice. Sometimes patients can transition from palliative care into hospice care if their symptoms are getting worse, and if there are unfortunately not any other treatment options or interventions that might help prevent or reverse the disease.
How would you know that you're ready for palliative care? Is it something that your doctor would bring up to you, or how would they decide when's the right time to do that?
Yeah, good question. So the question was, when should we think about palliative care? When should someone be, see a palliative care specialist or think about palliative care? And I'll kind of get to the next few slides,
Okay.
but it's good. Very good question. Like I said, for anyone who's having symptoms that are still occurring despite kind of what we're treating them for. So it's usually reserved for patients who have like a life-threatening or very severe illness. So someone, for example, with COPD is in that gold group E maybe status, and if they're having to be hospitalized frequently, like every month or every few months, are there ways that we can maybe help with their symptom burden, help them feel better, in addition to what they're being treated for. So if we're trying all these things back here, and maybe patients are still having issues, that's the time that we think about palliative care. It's been better studied in other conditions outside of lung conditions. So we typically think when palliative care was initially started in the United States, it was first started like in the 1970s, 1980s. Really kind of more reserved for patients with cancer, and being administered along their treatment course for their cancer. So if they're receiving chemotherapy, they'll typically maybe see a palliative care specialist. I'll get to the next couple slides.
Thank you.
So,
Thank you.
So for COPD specifically, it's sort of unknown about actually when to think about palliative care. A lot of times it'll be triggered to have a discussion about palliative care when someone's like in the hospital. If they have a really severe life-threatening flare-up, we might think about should palliative care start to be initiated. With COPD, this graph outlines, so on the x-axis here in the bottom is the time. So starting here at kind of time 0 now, and then looking over the next few years. And then this y-axis, looking at the low to high, is someone's kind of functional status. So how active can they be? Are they able to do things that they want to be able to do? Still care for themselves independently. So starting up here, their disease is not very severe, able to do all the things they want to do. And then the circle here is if someone has a flare or an exacerbation. That can make our lung function actually worse if we get a flare. That's what we try to do as much as we can to prevent someone from having flares. So the most common reason for a flare is an infection. So trying to make sure we do vaccinations and prevent exposures, secondhand tobacco smoke or someone still smoking. So they'll have a flare here, then they might hopefully recover, but they may not return all the way back to how they were before they got sick. And then this can then kind of slow over time. It can happen again if they have another flare, and the more and more flares someone has, some patients will keep having more and more flares. That's what we worry about for patients if they keep having flares, how do we prevent that cycle from happening? And then if more at the end of life is when patients are less functional, not being able to be as mobile, and that patients then can get really sick and not ever recover, and they may pass away. So we kind of, this can be sort of similar to a trajectory if someone has like heart failure, and has heart problems, if they get lots of fluid on their body, If their heart's not pumping well, it can kind of have a similar trajectory. So when in this time course is, when should we think about palliative care? I think sometimes early is always better, because the goal of palliative care is to help patients feel better. It's not that's separate from hospice, and it's really looking at ways can we help patients be able to be more active and feel better. And then there's some, this is why it's challenging, is when to think about palliative care. Is the risk of death after an exacerbation is very variable. So, you know, some patients will have only one exacerbation, be really severe, and not survive. Some patients will do okay and have one exacerbation just once a year and be able to get through it. So every patient is a little bit different. That's why we used to use the grading of the lung function, and that didn't correlate very well to someone's risk of getting worse. And we're using more of the symptom burden from a patient to look at what is their group of COPD. Any questions about kind of this slide here? I know sometimes not always something we want to talk about, but important to be honest with everyone.
The mortality rate after acute exacerbation, 23 to 80%. So that's a chance that, let's say you're hospitalized with acute respiratory failure. So you have a 23 to 80% chance of passing away from that?
So it's variable. So we don't have, we don't, that's why it's hard to, the question was kind of this variability in the mortality rate after an exacerbation. So not everyone is the same. Not every exacerbation is, you know, from an infection. There are other things that can trigger an exacerbation. So I don't always use this number when I'm talking to patients or talking to my trainees, the medical students or residents. It's really a individualized thing when talking with patients. But there is, I think what to take away from this is that there is a risk of dying and a risk of getting worse after a flare-up. So that's why we really try and prevent a flare from happening. It's really stressing.
People that have numerous exacerbations a year, not just hospitalized, but also the ones just at home on medication. So they're at a higher percentage of not making it through the next one.
Correct. And whether that percentage is 25 or 50, we don't
right.
Yeah. We do know that, say if we were to do lung function test after an exacerbation, usually the patient's lung function is going to be worse than it was 6 months before. So it is. Go ahead,
I say something about palliative care. I have a friend whose dad since passed away, but she was trying to get palliative care for him. And I don't know if y'all are aware of this, it's very, very hard. It's mostly they referred her constantly to hospice. And she wanted really palliative care. And when I called and tried to help her, I found only 2 companies providing palliative care. And they only would come once a month. The nurse would come in once a month. So how much palliative care is that?
Yeah, so the question is kind of the challenges of getting into a palliative care program and what does that look like? Unfortunately, the palliative care workforce is limited. So we try and we're trying to train more and more doctors and nurse practitioners and other physician assistants in palliative care so we can take care of our patients better. But throughout the United States, most palliative care programs can only see patients with cancer. So there's lots of other patients who are having issues even without lung disease, heart failure, patients with liver disease that are needing palliative care but don't have access to it. So I have extra training in hospice and palliative care. That's a combined extra training. Typically, palliative care is in the clinic and outpatient. There are some programs throughout the country that are able to come to your home and do home visits or do telemedicine visits, kind of like we're doing over Zoom here. So there are second-year frustration that there's not enough programs besides hospice, because hospice is different. Most hospice programs don't have a palliative care program.
Seems to me that
It should.
it's so many hospice programs. So many companies will do hospice and not do palliative. Is it more money in hospice? Do the government give them more money? You know, I'm thinking that.
It's really, so I'll get into a little bit at the end here, but hospice is kind of Medicare benefits, so at the end of life, so someone has to qualify for it. Anyone can qualify for palliative care. Like I said, palliative care is not to, we're not stopping treatment, we're continuing treating of the COPD or treating of the heart failure or other condition. That doesn't interfere with that. So I think the way our kind of health system is set up is hospice has been around longer, but we've recognized that not everyone needs hospice. They're not at risk of dying in the next 6 months, but also their patients are having lots of other symptoms that we need to do a better job of caring for that. So that's my interest. I have a palliative care clinic at VCU where I work to see patients with advanced lung disease, one of them being some patients with COPD. I'll get to the next few slides of what pulmonologists help with symptoms. But also we try and trying to train our new physicians and new doctors about what is palliative care and how can we deliver that without having to refer to a specialist, since there's only so few palliative care doctors throughout the country.
I want the policy of care. It came through my insurance, it's mostly telehealth, but they will come to the house. And I see them once a month, but when I'm sick, I see them every 2 weeks.
Yeah, there are different models, so I think it's been better incorporated into the cancer populations of patients who have had either leukemia or they have lung cancer. We actually know that patients, I did a study that patients who had stage 4 lung cancer, if they were also enrolled in a palliative care program, actually live longer than patients who didn't have palliative care with stage 4 lung cancer. We think, oh, that patient should live less if they're getting palliative care and hospice care, but actually it's not the case. So I think my hope is that we'll have more and more palliative care specialists in the future that we can support not just cancer patients. Of course, cancer patients are important, but there are a lot of other patients that we're missing who need help. It's hard in a 20-minute clinic visit if you're seeing your lung doctor or your primary care doctor to kind of talk about other symptoms that might be bothering you, not just your breathing, but there are other things that are going on that we need to address that we just don't have the time for.
How many people can you take into your palliative care clinic? And how do you get into the clinic?
Good question. So we are designing a website that you can call to self-refer. It's called the clinic at VCU. We have multiple clinics around the Richmond area. I see patients at the downtown adult outpatient pavilion, and then the Stony Point Clinic. And then I'll actually have other pulmonologists in the community or at VCU who refer patients to me, or if you have a lung doctor in the community, you can also refer to VCU. So, I don't have a website quite yet, but hopefully design one where you can Google pulmonary palliative care at VCU, and it'll pop up, and then you can call the clinic. So that's what like I said, it can be. I don't have a number of patients to say that. This clinic is newer that I started, so I'm happy to provide more information at the end of the talk if you'd like. There are other outside of VCU, other palliative care programs, like I said, they are kind of limited on what services they can provide outside, separate from hospice. Go ahead, ma'am.
Seems to me that if we have an episode, I forget the word you used, you would go to the hospital, and then that costs a lot more money than having palliative care. I'm assuming. So why isn't palliative care growing?
Yeah, good question. So the question was, why isn't palliative care growing? And if the goal is to try and help the symptoms and to keep patients out of the hospital, why aren't there more palliative care programs? For example, VCU's palliative care program, I think it's been around for maybe close to 20 years now, but there are only 2 to 3, we call fellows a year that they're training. In comparison, or to go into become an internist or a primary care doctor, there are 30 or 40 spots at VCU, so there's just not as many programs around the country to train palliative care specialists. So that's where we're trying to increase the workforce, but also trying to treat our newer medical students of these tenets of what's important, what is palliative care to help. They can incorporate that into the care in their general practice. So, and it's all about also the what is the patient's goals in terms of for their care. Some patients don't want to talk about hospice, or are not ready for hospice, so are still okay with or want to go back to the hospital for a condition that might be reversible. If they need to treat a pneumonia, then they're okay with going back to the hospital. Some patients don't want to go to the hospital at all, so it's really about the patient's wishes. And how do we? I'm not here to tell my patient what to do, but here to help them as best they can to make the best decision for themselves, what their wishes are. But I think that this talk kind of highlights, in my opinion, that I think having more and more palliative care providers would be helpful, so they can kind of help with symptoms, but part of also about, on the end of the talk, is what else palliative care can help with, which I'll get to kind of at the end here. This is what the goal, so the global initiative for chronic obstructive lung disease, that's our help create our guidelines, how we care for patients with COPD. That kind of 6-month, prediction of survival, we don't really know, we're not very good at predicting or prognosticating how someone's going to do with COPD. So, for example, we have a little bit better knowledge if someone has advanced cancer and what their prognosis might be. So this is where if someone is hospitalized, maybe that might trigger a discussion about palliative care. Or if someone is having lots of exacerbations in the, not requiring to be in the hospital, that might trigger more discussions or a referral. And then these red bullet points here are level of evidence that we have for these interventions. For example, and I'll talk about this in the next couple slides, but for example, for our evidence B, that's where we have sort of different types of medical trials that, our evidence A would be like a randomized controlled trial. If you've heard of those, those are our best studies to know what medications or what interventions work the best. Evidence B is where we have different types of trials, but maybe not a randomized controlled trial. And the evidence C is where you don't really have great data, maybe some smaller studies. For example, things like opiates, so pain medications have kind of some maybe lower level evidence that might help with symptoms. We get to, in the next few slides, I'll talk about kind of some of these different interventions that we can use to talk about how we help patients feel better in addition to the care they're already receiving with their inhalers or with their oxygen. But before I get to that, the other part of what we do in palliative care is what we call advanced care planning. Anyone heard of that term before? And it doesn't have to be a palliative care physician to have these discussions, but so your primary care doctor or your pulmonologist can have these discussions as well. And this really highlights the decision-making, someone's wishes about their future health care needs, especially in the times of like a medical crisis. Often it surrounds wishes regarding life-sustaining treatment and like resuscitation preferences. That meaning, wishes in terms of regard of going on a breathing machine or undergoing CPR, having those discussions with your doctor and with your family are those things you want to go through in terms of a medical crisis. I find it's helpful to have these conversations more in a quiet setting in the clinic and not in the hospital when you're not feeling well. If you're in the emergency room, you can't breathe, it can be hard to have these discussions about what your wishes are. And sometimes thinking, even though sometimes it might be hard to have these discussions, thinking about these things before someone gets sick, so you can tell your family, tell your friends kind of what your wishes are if things weren't or don't go well.
Yeah, could you clarify about the do not resuscitate? I think people have a kind of a misunderstanding or not a clear understanding. Nobody wants to be a vegetable, but they want to take every effort that they can be healthy.
Yeah. Good question. The question was about a DNR or do not resuscitate order. What does that mean? And sometimes can be the confusion around that. So I don't know if anyone's been asked this question if they've been in the hospital or what is your DNR status. Sometimes what that really means is if you're, say in an event, if your heart was to stop beating or if you're to stop breathing, what would your wishes be? And typically that means would you want to attempt at your heart to be restarted, so that means doing CPR or getting defibrillated, getting a shock, or if you were to stop breathing, would being placed on a ventilator be within your wishes? So putting a breathing tube down into your throat and having you hooked up to a ventilator to help with your breathing. I think your question is, most people don't want to be hooked up to machines indefinitely, don't want to be a vegetable. I think most patients want to be able to get through that crisis and get back to how they were before they got sick. So I sometimes like to think that trying doing what we call like a time-limited trial. So hey, if I have a pneumonia, I get really sick, maybe try and be on the ventilator for 1 to 2 weeks, see if I could get better, maybe get off the ventilator. But if you're not successful, not let me be hooked up to machines forever. And that can be outlined in someone's advanced directive. They can actually write that down and say, for a reversible condition, I would want to be resuscitated. I would want CPR. I would want to go on the ventilator. And you can even put kind of a time frame down. I also like to think that if someone has a condition where we can't fix, putting them on a ventilator actually cause more problems and maybe won't be successful. And that can be a discussion with your pulmonologist or your primary care doctor. If you have a condition where you can't fix, would a ventilator even help get you through that problem? So these discussions can be kind of nuanced and can be challenging, can change over time too, depending on what's going on. So I think having these discussions earlier can be helpful.
In Virginia, can you verbally revoke your DNR if you're able to in the emergency room and say, I've got a DNR, but let's not use it right now?
Yeah.
And then you can reinstate it 2 weeks later. If you can speak, you can revoke it.
You can, yes, same thing like with.
But I just had my wills and all those powers of attorneys done recently, and I put this kind of information into one of those.
Okay.
Powers of attorney for my husband, like reasonable expectations, a percentage of something, things like that, so I got all that squared away.
Yeah, there's different documents that can be very detailed or not very detailed. So for example, there's one form called the post form or post form. Every state has their own. Just one example that you can put down, for example, your wishes in terms of CPR. So usually CPR and a ventilator go hand in hand, are the same. I think it's the same thing. So, but some patients don't want to go under CPR, but would be okay with being on a ventilator. So you can kind of delineate certain things about your wishes, and then you can kind of then follow those. For example, if someone is not in cardiopulmonary arrest, their heart has not stopped, they still have a pulse, what intervention should we do? So for example, here you can check, I only want comfort measures. I don't want to be hooked to a ventilator. I don't want to be placed on a breathing mask. Even I don't want IV fluids. I just want to be comfortable. Then you can also, if that's not in line with your wishes, you could put in what interventions you would want. So it can be really very detailed or very not. So there's something called a durable DNR form, and that just really talks about this first part, A here, is really what, in the event if your heart were to stop beating, if you were to pass away, what your wishes would be in terms of trying to bring you back or not. And then you can the C column here, row, is things about like artificial feeding. So if you really get into more details about other interventions, feeding tubes or things like dialysis, you can all outline your wishes in terms of those goals. So you don't have to use this pulse form. You can make a lytic will and outline your wishes in another document. So there's different documents in different states have different laws. So, and then part of the kind of outlining your wishes is appointing what we call a medical power of attorney. So in Virginia, if you're married, your spouse is kind of your default medical power of attorney. If you're not married, then you can go kind of down this hierarchy of who would be your medical power of attorney if you didn't appoint one. And this varies by state, so different states have different laws in terms of who can make medical decisions. So, say if you were married and didn't want your spouse to make decisions for you, you could appoint a child, or you could appoint anyone. You could appoint a friend, but that has to be documented. In Virginia, a guardian supersedes even a spouse, so that'd be a different situation. But if you weren't married, then your adult children would be next in line. If you didn't have any children, then a parent. So kind of go down this pathway if you didn't appoint a power of attorney. This can be important if for some reason you were incapacitated or not able to make your wishes known, or you didn't have an advance directive. Who should we be speaking to? And if you didn't want your adult child for some reason, your son to be your medical decision maker, then maybe you should make a document appointing someone else. So, you run into this situation a lot in the hospital where you have to be able to find family or don't know someone's wishes. It's going to be a challenge. Someone may have said, I don't want to be hooked up to machines, but you can't find a document, or and they never express that to their family members. So it can be hard for families and loved ones to sometimes make decisions about next steps in care. So any questions about kind of advanced care planning? I said then You can go to an attorney and make a document, make a living will. You can also fill like this form out in the clinic to make your wishes known. So moving on to kind of end of the talk here, the next few slides, we'll kind of talk about what can we do in palliative care, maybe help with symptoms, help with breathlessness, maybe help with cough. If the things we're trying to do with the inhalers or with azithromycin or with oxygen, if we're still having issues, how can we help? So we use something called this MMRC, the Modified Medical Research Council Dyspnea Scale. So if you ever heard your lung doctor or even your primary care doctor, maybe ask you about how far can you walk or what gets you out of breath, we'll use these different grades to see how severe someone's breathlessness is. So 0 being I only get breathless when I exercise. That's normal. Grade 4 is the most severe dyspnea. Is that unable to leave the house because you're breathless, or even getting breathless doing activities such as dressing. The grade 2 is where we kind of cut off for looking at the different grouping of COPD. So that A, B, and E. If someone has more than grade 2 MMR dyspnea, that tells maybe someone's COPD is a little more severe. So that grade 2 means speaking to a patient in the clinic, I don't just ask them straight out, what's your dyspnea grade score? It's really, tell me about what can you do, what gets you out of breath, what's limiting to you, or what things, that can vary by the day too. It's really kind of an overall kind of picture. That's why I think it's hard with breathlessness. It is somewhat subjective, but it also is not. So it can be a challenge to kind of tease out how is someone really feeling. This is another, here, going back to the beginning, the graphs of the A, B, and E is looking at this CAT score is a little more helpful, but can be a little bit longer to get in clinics. So a lot of times I actually will have this form, some of my patients before you see the doctor, fill this out yourself and give us a score. There's other similar scoring systems, like for asthma, we'll have we call it asthma control test that asks certain questions about someone's asthma control. So we'll have a lot of these kind of questionnaires to help us figure out how is someone really doing. Thanks for kind of your question with the grading. This is a similar slide to maybe the one before about kind of the trajectory of COPD. This is kind of get back to the question, when should we integrate palliative care into the management of our lung patients and our pulmonary patients. So these are all the indications that have been studied that when should we think about enrolling someone in a palliative care program. So of course, if someone's having lots of symptoms that are bothersome, if families are expressing that they're having a hard time taking care of their loved one, that might trigger palliative care referral. Of course, being in the hospital for a really severe, life-threatening condition. Sometimes you think if someone's starting oxygen, that might indicate maybe the disease is getting worse, or that things might be progressing, but that's not always the case. If someone's being thought about being referred for a lung transplant, there's only a limited supply of organ for transplantation, so not every patient who gets listed for a lung transplant will get a lung transplant. These are some of the hospital indications to think about when should we enroll someone in palliative care. But there are other maybe models that are being kind of studied both here in the United States and also in other countries of having like a breathlessness clinic, integrating. This is sort of how I do it, is patients who have advanced COPD, I'm going to integrate that into my clinic. We're also having maybe more of a at-home program of pulmonary rehabilitation, having nurses and respiratory therapists, and maybe being available to come to the house to provide some of this care. So that is finishing up here. I'll get to my last 1 or 2 slides. I said palliative care. Patients with COPD are less likely to see palliative care than patients with lung cancer. So the things that we really know that work, that help with symptoms, are these 5 things here underneath this red, these treatments that can help. So actually the most important is actually pulmonary rehabilitation. So patients, pulmonary rehab is going to either a clinic or a hospital, 2 or 3 times a week for up to 12 weeks, and doing almost like physical therapy for your lungs. And that has been shown to actually help keep patients out of the hospital, help them feel better, and also maybe improve mortality too. So there are lots of barriers to pulmonary rehab. Unfortunately, there are only so many programs. There's sometimes a wait list. Our pulmonary rehab program at VCU is in the hospitals, and it's hard for patients to come to the hospital. There are home pulmonary rehab. You have to stop periodically, walking at your own pace. So we'll kind of ask these questions in the clinic to kind of get at what's someone's true symptom burden of their breathing. Any questions?
Is it normal that would like change? Like on a normal day, I'm fine. I only get short of breath on strenuous exercise. Then there are other days that I'm at grade 3.
Very good question. So the question was, can that change over time? And yes, so I think certainly someone's having a flare, they're going to have a worsening grade of their dyspnea. But if someone has, for example, COPD and heart failure, could having extra fluid in their lungs, their heart's not working well, can that make their breathlessness worse? So it can change, and actually we track this MMRC if someone does pulmonary rehabilitation, can we improve their grade of their dyspnea?
I feel that grade 4, I'm breathless when dressing, shouldn't be on grade 4. I think that should be more on 2 and 3. Because I think being breathless when you're dressing happens to most of us who have COPD. And I don't think that means that I'm necessarily grade 4. I feel that I'm more 3.
Good question, Ed. I know a little bit about the grading. Is there some subjectiveness to it? And I think there definitely is. So that's why there's something else that we use too that I don't know if you've ever seen before. Instead of asking someone how far can they walk or getting out of breath, there's something called the COPD assessment test. This is the CAT score. This is a little bit more questions that we ask about someone's symptoms. So I don't know if you all can see it, but they ask questions about coughing, about having how much mucus is someone having in their chest, having any chest tightness. How about walking up a hill? About any activity limited in the home? Are you confident about leaving your home with your lung condition? Things about sleep. Things about your energy level. And these scores are from 0 to 5. So 0 for saying I never have a cough, but 5 being I cough all the time. And then this score is out of so 5, 10, 15, 20, 25, 30, 50. So a score more than 10, actually, that sort of equates to grade 2 MMRC. So it's a little bit more, I said, this is very subjective, I think. This grading is even sometimes hard to your phone or your computer. And then so that's really the best thing is pulmonary rehab. So we have looked at things, like I said earlier, tried things like pain medications that can help with breathing. So, for example, morphine at lower doses might help improve breathlessness. Things here at the bottom, so, for example, benzodiazepines, things like Ativan or diazepam, necessarily don't help with breathing, but can help with anxiety, which can be a vicious cycle. Breathlessness can trigger anxiety, anxiety can trigger breathlessness. And I'll just finish up here at the end. This is kind of a busy slide, but this is what palliative care can do for any patient, but especially with COPD. So we look at the physical aspects of care, how we're caring for the patient. We talk about advanced care planning, and we're also looking at, here in the top right, the kind of psychiatric and psychological aspects of care. And then the bottom right here is looking at kind of the social aspects of care, how we can care for kind of the social needs of the patient, not just the physical needs. That'll end my talk, but I appreciate you having me here, and happy to answer any other questions you all have.
That was really good.
That has to be one of our best. And seriously, just thank you so much for taking the questions. They were fabulous questions.
Great questions, yeah. You like questions in the clinic, so it can be confusing a lot of these things.
Right.